I was invited to give this lecture on the surgeon perspective of neoadjuvant immunotherapy in the context of a debate session with the radiotherapist. First of all, it is important to notice that about 25% of patients with non-small cell lung cancer present at this stage, which is a locally advanced stage of lung cancer, meaning that in addition to the local treatment, which could be surgery or radiotherapy, they definitely need some systemic form of treatment like chemotherapy and most recently immunotherapy in combination with chemotherapy has been trialed and tested in several ongoing phase 2 and phase 3 trials. So the important thing is that this patient cannot be treated alone or with surgery alone or radiotherapy alone. They need some form of systemic treatment. Now, the surgical role obviously is important for or dedicated focus on patients who are fit for surgery. And there have been some studies showing that neoadjuvant chemotherapy, traditional chemotherapy, doesn't increase the risk of perioperative complication or mortality after surgery compared to surgery alone. So that's important to understand. But of course, surgery has a price, especially for those patients less fit, and the elderly patients. We know from large series that this patient can have a substantial morbidity and mortality rate. So fitness for surgery is a priority and need to be assessed before considering a patient for surgery, especially because with this stage, surgery is generally not less than a lobectomy, often a bilobectomy, 20-30% of cases in pneumonectomy because of the size and stage of the tumor. So it's an extensive surgery which has a considerable impact on the patient. And often surgery is performed through an open approach in this stage because of the large size, the location, the complexity of surgery. And we know that open surgery is associated with more complication than minimally invasive surgery. So all these need to be taken into consideration when discussing the case at the multidisciplinary team meeting or during shared decision making with the patient. So I've never seen radiotherapy as a competitor to surgery in this group of patients, but even in early stage. So patient fitness, patient preferences should always be taken into account, and radiotherapy should be regarded as a valuable alternative to surgery in patients deemed unfit or too high risk for surgery, or for those who decline surgery. However, when possible, surgery may also offer two additional advantages or benefits compared to radiotherapy. First of all, there is a growing number of papers showing that the completeness of lymph node dissection, so the lymphadenectomy that we always associate to lung resection, is also associated with improved survival, even in node-positive patients or in patients with N2 disease. And there is a great push to rate the quality of surgery based on and completeness of resection based on accuracy and completeness of lymph node staging and dissection. And obviously, this cannot be achieved with radiotherapy alone. And the other aspect is that I will cover in this lecture is the heterogeneity of the tumor. The primary tumor and the lymph node metastasis may differ in terms of genetic and mutational profile. So there is a 30% of tumor with discrepant mutations in the primary and tumor and the lymph nodes, which is important to know because the current standard is just to biopsy the most representative lesion, which may not be representative of the entire heterogeneity of the tumor, and only a complete lymph node dissection, the removal of all the lymph node and the molecular testing of both the primary and the lymph node will ensure to accurately profile the tumor, which may drive targeted treatment in these patients. So these are the most important points that I will cover in my lecture.